Hey there, everyone. So today we're going to talk about if exercise increases or decreases the risk of developing osteoarthritis. So I'm Chad Cochran, and this presentation was put together by myself and my group members, Catherine Donnelly and Tori Anderson Vale. So what is OA? So osteoarthritis is referred to as a degenerative joint disease or degenerative arthritis. So it's the most common age-related rheumatic disease and a major cause of chronic pain, affecting approximately 52.5 million adults, or about 23% of the population. So it can affect almost any joint. Knees and hips, lower back are usually some of the more affected ones. According to our textbook, in the United States, approximately 80% of people over the age of 65, and essentially everyone over the age of 80, has some form of osteoarthritis. So what's your articular cartilage made of? So 70 to 85% of it's water, with the remaining 15 to 30% being proteoglycans, lipids, and collagen. So 60 to 70% of your dry weight in your cartilage is made of type 2 collagen. If you remember, type 1 collagen primarily makes bone, type 2 collagen primarily makes cartilage. And then about 30% of the dry weight comes from proteoglycans, which include your chondroitin sulfate, keratin sulfate, which attach to the protein core, which attach to the hyaluronic acid backbone. And then lipids provide the remainder, which is a small portion of it. So proteoglycans are a bottle brush-like structure consisting of a protein core with side chains of chondroitin sulfate and keratin sulfate. Negatively charged sites on the chondroitin and keratin sulfate chains cause the aggregate to spread out and occupy a large domain when placed in an aqueous solution. So when combined with the collagen framework, these proteoglycans are not able to expand to the same degree, which is actually beneficial to their function. When the cartilage is compressed, these negatively charged ends are forced closer together, which increases the repulsion forces and actually increases the stiffness of the cartilage, which means they are better at resisting compressive loads, exactly what we need our articular cartilage to do. So why is osteoarthritis bad? So in normal joints, cartilage covers the end of each bone to provide a gliding surface and cushion for joints in motion. In OA, the cartilage breaks down, exposing the bone, which causes pain, swelling, and stiffness. As OA develops, there is a disruption of the cartilage matrix, which results in an increased water content, altering the mechanical properties of the cartilage. Tensile failure stress of the cartilage in joints such as the knee and hip decrease with age, meaning that cartilage no longer provides the same protection to the surface of the bone, or in essence the same shock absorbing capability that it once did. Over time, cartilage continues to break down, bone spurs develop, cartilage is further damaged, and ultimately bone rubs against bone, leading to more joint pain, swelling, and damage. So why is this important? OA is difficult to study in human populations despite its widespread occurrence. Early physical symptoms such as fibrillation and cracking at the articular surface are difficult to detect due to cartilage being aneural, so it doesn't have any nerve endings. So you don't really feel any pain until you hit the bone. According to Otis, damage to this cartilage may take years to progress to the point at which symptoms are detected by the surrounding joint structures and underlying bone, and everyone's different. So you could take two patients with the same degree of degeneration. One may not be able to walk at all due to the pain. The other may only complain of minor pain and swelling. So numerous epidemiological studies have been performed. However, they have not led to an explanation of the mechanisms underlying the development of OA, only possible risk factors and possible causes. So some possible risk factors include older age, obesity, osteoporosis, previous trauma. Genetic factors, often a thing that have led to variability between patients. But interestingly enough, physical activity does play some role, but to what extent we'll get into. So some of the clinical findings for OA. So it's typically diagnosed by history and physical. Some signs that may point to it are the pain that worsens with activity, improves with rest, the joint instability, early morning stiffness that improves throughout the day, or stiffness with long periods of rest. And also OA of the spine can lead to nerve impingement and cause radicular symptoms depending on the level of damage. So some radiographic findings. and these can all be different depending on the patient. So typically you see non-uniform joint space narrowing, which may be minimal early on in disease. You'll see osteophyte formation. You'll see some subchondral cyst formation and subchondral sclerosis. So in picture A here, we have an AP view of the left knee that shows some medial joint space narrowing. In picture B, we have a lateral view of the left knee, which shows the sclerosis, which is marked by the arrows. Osteophytes are also seen here and here. In picture C, we have a different patient with marked joint space narrowing on the left. You can see the joint space is pretty much collapsed. The bright white area shows you some sclerotic bone. And then in D, it's hard to see in this picture, but there's a subchondral cyst right there. So Sutton, Muir, Mockett, and Fenton in 2001 said that, so we know that regular exercise can cause decreased risks of cardiovascular disease, improve weight loss, increase strength, lower blood pressure, and provide improvements in mood and well-being. There remains some concern, though, that with this increase in exercise, the risk for osteoarthritis can also be increased. It can be argued that the high levels of activity, which can lead to an increased risk, especially if an injury has occurred. So Otis says exercise and activities that involve torsional loading, fast acceleration and deceleration, and other forms of excessive or abnormal joint loading appear to increase the risk of developing OA. However, some level of loading is beneficial. So Bosworth in 2009 found that the risk of OA might be increased in the presence of obesity, trauma, overuse stress, and alignment problems of the lower extremity. So there might be increased risk with competitive sports participation at elite levels. On the other end of the spectrum, though, low levels activity could lead to the increased risk of overweight and obesity, which can lead to the increased risk of developing OA. So what are some things that can lead to a decreased risk of developing OA? So there were a few studies done that dealt with glycosaminoglycans. So Tidarius, Svensson, Leder, Ola, and Dahlberg in 2004 performed the first study to provide evidence that human cartilage is adaptable. They found that glycosaminoglycan content is lower in the knees of sedentary individuals. Low GAG content leads to increased susceptibility to OA, so the authors hypothesized that the exercise may be preventative. So Roos and Dahlberg in 2005 found an increase in GAG in the knees of at-risk patients after participating in an exercise regimen 3 times a week for 4 months. So what are these glycosaminoglycans? So GAGs are essentially polysaccharides that make up the proteoglycans throughout the body. So chondroitin sulfate, keratan sulfate, hyaluronic acid, which are all essential to the structure and function of the articular cartilage, as I mentioned earlier, are all GAGs. So evidence also found by Bosworth in 2009 suggests that moderate levels of exercise do not accelerate the development of knee OA. There is evidence for reduction in lower extremity disability in self-selected runners, though, when compared with controls. So active or passive joint movement has a positive effect on articular cartilage. Cartilage matrix production is sensitive to the hydrostatic pressure or deformation caused by joint movement, according to Otis, meaning that the actual movement of the joint causes it to produce more matrix, which can provide benefit later in life. Maintaining articular cartilage throughout the lifespan should be a common goal for all people, as it helps to maintain proper mechanics and functionality of a joint. So we know that increased activity can lead to increased risk for injury, and as a result could lead to an increased risk of developing OA. In our opinion, though, moderation is key. The risk for osteoarthritis might be increased in the presence of obesity, trauma, overuse stress, and alignment problems of the lower extremity. There still remains little evidence to suggest that regular physical activity increases the risk of knee osteoarthritis, though, unless an injury has occurred. So we also know that lower levels of glycosaminoglycans have been found in sedentary individuals, and that can increase the susceptibility to osteoarthritis. And we know that activity increases the presence of these glycosaminoglycans. So exercise has been shown to be beneficial to those individuals who have already developed OA, and it has proven to be beneficial in the prevention of numerous other pathologies. At this time, it seems the benefits of moderate exercise outweigh the negative risk associated with developing osteoarthritis. And these are our references. Thanks.